I would now like to invite the next speaker, Dr. Rafaele Aspide. I hope I have pronounced it correctly. He's a neurointensivist and neuroanesthesiologist at the Bologna Neuroscience Institute. He has expertise in the practice of brain parenchymal ultrasound transcranial Doppler as a member of the Italian Society of Neurosonology. He is also a tutor of neuroanesthesia residents in the University of Bologna. He has published multiple peer-reviewed articles in well-known journals and book chapters. I welcome Dr. Rafaele Aspide. I hope I have pronounced you correctly.
Yes, exactly, Rafaele Aspide.
Thank you.
Thank you for your invitation. I'm really glad to be here, and it's an honor for me. And I'm sorry for the delay of the daily scheduling. I'm sorry even for my poor English. I come from an old institution hospital that is in Bologna, in the north of Italy, and we started with the neurosurgery in 1958, I think, was the third experience in Italy. And I'm very glad for this invitation for all scientific committee that decided to invite me and the people that can meet tomorrow in the ENLS course. This is my presentation, and my role, like always in the afternoon, is to wake up you in the post-lunch section, in which everybody can try to start and sleep this heavy discussion. I have no conflict on this topic. And about my topic here in India, I started searching some paper around, and I found it that the main cases of a subarachnoid hemorrhage is traumatic, and probably in the next 15 years, following the neurology India, this become the 5th cases of death because of the road traffic accident. You know that in the paper 50% of the things and data are false, but following the road traffic between Mumbai and Pune, I believe in that. We focused our discussion on no traumatic subarachnoid hemorrhage, in which the aneurysm is the 18%, and the other causes are arteriovenous malformation or cinematuria, when science has no words, cinematuria. The incidence of this disease is enough high. Something like 6 or 7 persons in this room have an aneurysm, but not of them is go to the rupture and extravasant blood. Only this guy face this experience. In our institution, we mostly follow these incidents, and we face something like 16, 18 subarachnoid hemorrhage per year, because we cover a 1 million area. So this is the number, this is true. And but the problem is that the subarachnoid hemorrhage is really a small part of all stroke disease that we can face in emergency room or in ICU. The problem is the quality of life here lost, that on this scenario is really worse than facing on the ischemic stroke. So, like my boss say every day, is a medical disease. Okay, let's analyze this scheme. This is the idea of presentation. We have in good condition 3 patients on 6, 2 patients in the mild condition, and 1 patient really in bad condition at the beginning. In the second step, one of the 3 became part of the second group with the mild condition. At the end of this story, you recognize something like 50% of disability, 33% of death, and only 17% percent of full recovery, and this is true also. Following the topics of this meeting, this is the only guideline, the newest that we have, are not so new. Like you see, this is for from USA culture. This is from European Scientific Committee of Stroke Organization, and we are waiting for a new one. So we start from these guidelines to write in Bologna, in our area, these documents that is focused on our population, that now is diffused for all region, that is 4,400,000, like you read inhabitants. We try to manage all steps outside the hospital, emergency room, and the treatment approach, and rehab management, collecting all data inside this database. And our documents become a regional documents, and we hope to spread these documents all over Italy if will be possible. And Emilia-Romagna is a region that is in the north of Italy, like I show you. But about the subarachnoid hemorrhage, the clinical presentation, like you already know for sure, is a severe headache. And it's the worst headache that you can meet in your life, that patients feel in his life. Is symptoms like a thunderclap, and sometimes is followed by sign of meninges, like nausea, vomiting, Kerning and Brzezinski sign, but not always. And there are a lot of subarachnoid hemorrhage that appear without these symptoms. In our experience in Bologna, we try to train in most part of physicians in emergency room to recognize, identify the different headache. And we established the creation of stroke code that probably you already use, like in UK, for example. This thunderclap headache is sometimes not so classic. Be careful. There are 40% of patients that have a normal neurological exam without any kind of meningismus sign, and there are a lot of patients that respond very well to the narcotic. What we use to assess this stroke condition, always the Glasgow Coma Scale, the 4 score that is pretty new, but is if added to GCS, it will be useful to define the brain stem condition. Inside they have, there is pupil exams. And obviously the World Federation Neurological Scale and ANTES clinical grading scale. There are 2 scores dedicated to the subarachnoid hemorrhage, like we learn tomorrow in ENLS. The gold standard about the sensitivity, close to 100%, is no contrast CT scan, like you already know, nothing new. But we know that if the time is go on and the patients present anemia, or the subarachnoid hemorrhage is a low volume hemorrhage, or the CT scan is technical poor, is not read by an experienced neuroradiologist, the sensitivity can fall down, like in the time, like I show you in these graphics. So when we perform a CT scan that appear negative and the symptoms and signs suggest for a subarachnoid hemorrhage, we started performing the lumbar puncture, like as you know already. The lumbar puncture is the rationale for to confirm the xanthochromia that needs some hours after the beginning of the symptoms, and is a time-dependent symptoms. This is a guideline dedicated to minimize the complication of a lumbar puncture complication, even using echo, but never mind. And if you want to adjust the brain imaging, you normally perform a CTA to diagnose the aneurysms sometimes, or CT perfusion in some institution. Not in our institution. We don't currently use CT perfusion for each patient. And obviously angiography to starting the treatment. In our experience, we perform in the first 6 hours the 98% of CTA to the subarachnoid hemorrhage patients. This is really important to have a fast diagnosis. And after that, the treatment. These are our hero in the suite of neuroradiologists, and they spend a lot of time in the kitchen, but sometimes they work. And this is the surgeon that performed the clipping. So from our side, from intensivist side, the most important things is to reduce the change in aneurysmal rerupture. That is really a tremendous consequence of the time if you wait and lose the possibility to close the hole. So which are the initial order? You already knows, because how many of you already faced a subarachnoid hemorrhage in the emergency room? Yeah, less than half. And this is what we say, like initial order: bed rest, labs, the 12 leads, ECG, and starting with the nimodipine, oral nimodipine, 16 milligrams each 4 hours. So it's very boring therapy, but it's really important. Be careful about the hypotension. Obviously, we awake our neurosurgeon. The prophylaxis and management of seizure is inside there are no trial about that, but we know that there is a pro, because early seizure are really a cause of rerupture and rising of ICP that is dangerous. But we know that phenytoin is associated with a worse cognitive outcome. So if we have an active seizure, we manage with lorazepam. If not, we start with a short therapy of Keppra, levotiracetam, in our experience. This paper is pretty good about the anti-epileptic drugs management in critical ill patients. This is a complex slide about the blood pressure management, but probably is the most important things, because we don't have a clear indication from guideline about the blood pressure management. We know from the guidelines that we manage the median artery pressure under 110 millimeters of mercury, and the systolic blood pressure under 116. But if aneurysm is unsecret, the guide is the neurological improvement. So we can follow the map using other kind of neuromonitoring device, as the NIRS, the TCD, the focal monitoring like PBTO2, and we do that. You can reach this value of medial artery target only after the secret aneurysm, for sure. But the individual map target is different patient by patient, because in two different conditions, you can understand that this is a patient with a high risk of cardiovascular complication, and she is an excellent cardiovascular reserve, for sure. So it's important to use instruments that are able to give us the idea of if it's a salvageable brain under our hand, you know? What we consider like the case of neuroworsening, like I told you, re-rupture, that is a case of 12-15% in the first 24 hours. But at the same time, even the seizure, like I told you before, and the hydrocephalus, or the non-neurological complication, as the cardiomyopathy, neurogenic stress, the cardiovascular collapses, that can causes by neurogenic pulmonary edema. Don't forget about that. So another spot that is outside the guideline because there is uncertain result about the trials, that the using of the antifibrinolytic agent like tranexamic acid is dangerous for the patients affected by myocardial infarct or DVT or pulmonary embolism. But we normally use 1 gram each 24 hours for the first 72 hours if we found blood in the ventricle, for example. The hydrocephalus is dangerous for rising ICP, and it is a matter of surgery, and we manage with the endoventricular drainage that we use even for monitoring and drainage at the same time. If neurosurgeons are still sleeping, we can start with the mannitol or hypertonic saline. So, a small resume. This is the presentation. This is the worst condition that we can face. Cerebral perfusion pressure 0 is diet. Stress cardiopulmonary myopathy. In the first 72 hours, we can face hydrocephalus or rebleeding, like I told you. In the last step, we can face vasospasm, hyponatremia, that is really dangerous, and thromboembolic and ventriculitis because of the AVD. Why we used to manage sodium serum level? We check it even 4-6 hourly, and we control if it's going down because it's a part of tires of prevention of intracranial hypertension and management of herniation. So we follow symptom and we start with the therapeutic infusion of normal saline on upper concentration, even to 23%, obvious through the central line. Who of you use transcranial Doppler? Nobody. We love transcranial Doppler, and we know that if there is an asymmetry is very bad, if velocity out of range is very bad, and the relationship between median cerebral artery and interior carotid artery, Lindegar index superior 3, are really bad. But even we know that there lack spatial resolution. In our experience in Bologna, we face this disease involving in this patchway even the neurorehabilitation, the physiatrics and the speech therapist in the first 48 hours, starting with the passive and then active rehabilitation and the evaluation of swallow and phonation like aphasia. This is gel water. Is a great product from a business company, is water. And this is one of the papers that we consider. So, like a final resume, this is the idea of the disease in the time. If we start from day 0 in unsacred aneurysm, like I told you, and you face in this part of the strategy, following the CTA after the CTP, or facing the vasospasm, management, the hyponatremia, the use of other kind of neuromonitoring, the augmentation of MAP, And the blood pressure management, like I told you, the use of an imodipine peros, and considering in the bad situation the target management temperature. Don't forget, like I told you, the neurogenic edema, pulmonary edema that can cause lung desaturation, and cardiomyopathy stress syndrome, Japanese octopus. The heart is moving in this way. This is our town, and this is our intensive care unit that is in intensive care of 12 beds and 4 beds of post-op. And I hope to see you again, and thanks you for your kind attention. Contact us. Thank you. I think we have some question. Very easy. This is dedicated to what's happening after the CT scan is negative. What is the next diagnostic step? Please vote. No choice is correct. Lumbar puncture, looking for xanthochromia. The next one. This is about no contrast brain CT, what's happening in the time. Okay, you choose C because the sensitive, like I told you, is 100%, 95, 100%. Don't forget the 3 rules: anemia, poor scan, and the small hematoma. Thank you.
I would like to request Dr. Atul Deshpande sir to kindly felicitate Dr. Rafael.